All right, I'll get us started because we have a packed webinar today, and we're so glad to see so many people join for this topic. It's such an important one. It's often something we can all learn more about, and we're very lucky to have a really expert discussant with us today. I'm Anna Chodos. I'm the Executive Director of Dementia Care Aware, and I will be moderating our webinar today. Dementia Care Aware is a DHCS initiative and led as well here through UCSF. And we are in partnership for a lot of our work with UCLA Health in the Alzheimer's and Dementia Care program, which you'll hear more about. Our topic today for this August webinar is Behavioral Symptoms in Dementia, Part 1, Assessment and Initial Care Plan. Our discussant and presenter today is Michelle Panlilio. She is the National Lead Dementia Care Specialist at the UCLA Alzheimer's and Dementia Care Program. I also already briefly introduced myself, but I'm here at UCSF. I'm in geriatrics and internal medicine. And I would like to give Michelle an additional opportunity to say a little more about what she does so we all know why she's presenting the topic today.
Hi, everyone. Good afternoon. I'm Michelle Panlilio. Thank you, Dr. Chodos, for the introduction. So by trade, I'm a geriatric nurse practitioner. And while I do still see quite a bit of patients, I've been a dementia care specialist at UCLA for a little bit over 10 years, so quite a bit of time. The chunk of my role right now is spent on disseminating the ADC program. So very excited to be here. Thank you so much for attending.
Thank you, Michelle. We're really lucky to have you. I'm really looking forward to the talk, and I'm sure everybody else is as well, which is why so many people are tuning in today. I want to make sure people have a sense of the logistics. As Michelle's presenting, I will be looking at the chat and the Q&A and being sure to answer what questions I can in the moment. And we're also hoping to have a good number of minutes at the end to get to questions live. So by all means, feel free to put your questions in the chat and Q&A as we go through. I'll monitor both. Usually Q&A is a little easier for folks during the webinar. And we'll be getting back to what questions we can't answer through the live webinar. So really appreciate you guys participating as much as you can. The questions always help us get to the information that's most useful to you, which is really our goal. So continuing on, neither of us have any relevant financial disclosures. And we always like to remind everybody really briefly of what Dementia Care Aware is offering. So we have a warm line for live support from 9 to 5, Monday through Friday, where you can talk to one of our clinical experts about dementia care. We have trainings online, including our core cognitive health assessment. We have webinars like this one, and we have live training opportunities where we can do the core cognitive health assessment training and other topics like medical, legal topics in a live session, like a virtual webinar or other type of presentation. And then we have our podcast, which most of these opportunities, including the podcast, offer CME. We also have interactive case conferences in the ECHO model led by UCLA and UCI, and you can find registration information on our website. And then we have, as Michelle represents, the ADC program and Alzheimer's Association have health coaching practice implementation coaching for practices that want to transform what they're doing in primary care to be more dementia friendly and capable. So please visit our website or email us at any time if you have questions about any of these offerings, excuse me. And then we have our core training, and we always like to get back to this briefly, because this is really the jumping off point for DCA, which is we want to encourage people to do earlier detection. And earlier detection really is akin to screening. So we have our core module, the Cognitive Health Assessment, the Basics course, which gives you 1.5 credits of CME or continuing education credits and can be done at your own pace, and goes over the fundamentals of the Cognitive Health Assessment, which is meant to be an annual assessment like any other screening for adults 65 and older who don't already have a diagnosis of dementia. And the components are a brief history, like one single question about if they're having symptoms, a validated tool to screen for cognition and functional decline. And then finally, a brief review, which this is not part of a clinical assessment, but more how can we care and support our patients and their support systems, which is the last part, is documenting their care partner information. So we know who's in their life and who's supporting them, and including, very importantly, if someone does not have a support system, we may do things differently. So this is our opportunity to start screening and to start brain health activities with folks, especially if they're positive on any components of this screen. And so today we're really talking about behavioral symptoms of dementia. That seems pretty far down the path of screening for dementia, but we really wanted to emphasize that starting off with the cognitive health assessment, getting acquainted with the Dementia Care Aware program, you'll see that screening, again, is just the beginning, and it's part of a pathway in which we're trying to detect people with symptoms or signs of decline, make a diagnosis through a thorough evaluation, and then ultimately continue to manage symptoms that are coming up. And so I'm showing you this today to just point out that it's really a whole pathway to diagnosis and care. And we care very much about all of it. And particularly behavioral symptoms are really can often be a large and complicated and ongoing part of clinical management. So that's why today's topic is so important. I'll proceed to let Michelle take over. And again, so grateful. And I'll be in the back looking at everyone's comments and questions. And a reminder that everything, including the video and the slides, will be available after the webinar for people. Michelle, I'll pass it to you.
Thank you so much, Dr. Chodas. All right, so today we have a pretty packed agenda. And so we have a lot of topics that we are going to be talking about today. But the main purposes for the main learning objectives for today's presentation is that we're going to talk about the purpose of the Neuropsychiatric Inventory Questionnaire, which is what I'll be calling as the NPIQ. And this is a tool that we use to look and assess and evaluate behavioral problems in dementia. Another learning objective is that we are going to be able to identify at least 5 common behavioral problems, behavioral and psychological symptoms of dementia. And then the last objective for today's presentation is that we are going to look at the behavioral problems, but also we're going to start making an initial care plan to address the behavioral problems. Next slide, please. Okay, so just to give a brief background on behavioral problems, it is something that happens in the majority of patients with dementia over their lifetime. Typically, when we are looking at patients who get their MMSE or their MoCA tested, generally we do expect to see about 3 points or 4 points to drop every year that we assess our patients. And we do the mini mental and the MoCA both in our program. Unless there is something that will cause a significant drop in the patient's cognitive function, such as a hospitalization or some kind of an injury or some kind of other significant event. For our patients, unfortunately, about 80 to 85% of them will experience some kind of agitation or aggression during the course of the disease. Next slide, please. Okay, so some key concepts in managing behavioral problems. To treat or not to treat, that is actually a really good question. And so what I mean by that statement is that not all behavioral problems have to be treated. And so in order for clinicians to figure out, is this something that we really need to medicate for or not? Is it something that we're going to wait for? You really need to ask the right questions from the family and clarify what the understanding is of the caregivers. And so we'll go through that as we go through each behavior. Just a quick reminder again that today is actually just the first part of two parts of the presentation. And so today we're going to be talking about assessment, but the next webinar, which is scheduled in October 24th, that's a time when we are going to be talking about behavioral modifications for these for the psychotic behaviors. Next slide, please. Okay, so the Neuropsychiatric Inventory Questionnaire, the NPIQ. Next slide, please. Quick introduction on this tool. So it is a questionnaire, and it's a questionnaire that we typically will collect from our patients and their caregivers during the annual appointments, and also when they first establish care with our program. And it's a validated tool based on the caregiver's report. So it's actually the caregiver who is filling this tool out. And ideally, they should be filling out that tool based on the patient's behaviors in the past month. So it measures 3 things on 12 different domains. So it measures the presence of the behavior. And then if the caregiver does fill out a positive behavior, then we will typically ask them to complete the severity of the behavior and also the stress levels on the caregiver. Now, typically it says that it's about 5 minutes to complete, but in reality, it's actually a lot longer than that. Although it might take the families and the caregivers 5 minutes to complete on their own, like once they bring it into the office, because we are doing such a thorough evaluation and we're really exploring their answers, about 15 to 20 minutes is more realistic. But it is very important to discuss the caregiver's answers, because this is going to help you determine your plan of care and how you're going to approach it. The NPIQ tool, just an FYI, it was developed by Dr. Jeffrey Cummings, and it's copyrighted unless you are using it nonprofit. Next slide, please. Okay, so I had mentioned that it measures 12 domains. And so these are the 12 domains that we're going to be talking about today. Next slide, please. And just very briefly, this is a picture of what our questionnaire and what the caregivers will fill out when they come into the office. Next slide, please. So I wanted to kind of enlarge just one questionnaire. This is talking about delusion specifically. And as I mentioned, the tool is actually looking at 3 different components of each behavior. And so the family is asked, does the patient have false beliefs, such as thinking that others are stealing from them? So basically delusions. If they answer no, then they are asked to move on to the next behavior. But if they circle yes, then they are also asked to complete the severity. So 1, 2, or 3, generally meaning, mild, moderate, or severe. And then the stress levels on the caregiver. So 0 meaning it's not bothersome for them at all, and it doesn't interfere with their day. Or a level 5, which means that the behavior is very, very bothersome for the family or the caregivers. Next slide, please. Okay, so actually identifying the behavioral and psychological symptoms of dementia, BPSD. Next slide, please. All right, so delusions are one of the most common behaviors that our patients will have when they present into our office. Delusions, again, they're false beliefs. And I think the most common one that we typically will encounter for our patients, and perhaps you have encountered this with your patients, are that my spouse or my loved one is having an affair, and it's very bothersome to me. It could also be that the patient will accuse their caregivers or family of stealing from them. Sometimes it could be neighbors are trying to conspire against them. It could be something like that. Delusions of grandeur are a little bit less common. And Capgras syndrome, I'm not sure if many of you have encountered this with your patient, but Capgras syndrome, it's a belief that the patient will have that the people who are taking care of them, and it's usually one particular, like the primary caregiver, it's believing that they are not who they are saying they are. And so you can imagine this would be bothersome. For example, if there was a husband who's taking care of his wife and he's trying to give her medications and take her to doctor's appointments and help her with her ADLs, you can imagine how bothersome it would be if the patient felt that, no, this is not my husband. I've actually had patients with this, and they will say something like, why are you here? Why are you in my house? Get out of my house. And so that's some of the behaviors that you might see. I think it's important to note that the symptoms are very real to the patient. And it's not that they're making it up. It's really that they do truly believe that whatever delusion they're having is actually their reality. Next slide, please. Hallucinations, just to identify this behavior very quickly, hallucinations are false visions or voices. And so it could be that your patient may be reporting things that they hear, when they're really not there. So I think one of the most common hallucinations that we get are, insects or birds that are making sounds. Another type of hallucination is, visual hallucinations. And this is when the patient will see either a person or sometimes animals or insects that are not really there. I think one of the more common hallucinations that we may have is that the patient is reporting intruders coming into their home. And, certainly, I think we can understand why that would be very bothersome to our patients if they think that they have intruders in their home. And this could lead to things like, leaving their house, going off to wander, certainly anxiety and agitation. Next slide, please. Okay, and this is aggression and also agitation. So I love this picture of this woman. I think it's we've all had patients who look like that. As far as aggression and agitation, we actually use it loosely, but there are actually different types of aggression and agitation. It's important to note that agitation and aggression is the number one reason for our patients to be removed out of the home. And whether they're placed in a facility or sometimes they need to go into the hospital. Unfortunately, again, these are just like really bad clinical outcomes. So as far as the variations on aggression can be pretty mild, and it could be, the patient telling their caregivers or their family, stop telling me what to do, you're not the owner of me, leave me alone, go away. It can be that mild in its, verbal agitation. It could also be quite severe in that the patient will be aggressive. There'll be physical aggression, and it could lead to the patient or the caregiver getting hurt. This is often, we can often see this when our patients are resisting help from caregivers or family members, or sometimes, threatening families and caregivers. I think I just also wanted to mention that as far as the patient, always make sure that when you're doing your assessment that you assess the patient's ability to actually inflict harm. Because, for example, if you have a patient who is in their 80s and they are frail and they are bedridden, I wouldn't worry so much about them hurting caregivers, or at least not as bad. However, if you have a patient with, let's say, frontotemporal dementia, and they are, 48 years old and are able-bodied and a lot stronger, then we always have to make sure that we are assessing for the patient's ability to inflict harm on their caregivers, as well as other people. Next slide, please. Okay, depression. So depression tends to be a little bit more challenging to evaluate in our patients. We actually use the Cornell scale for depression in addition to the NPIQ. But depression, it's challenging because sometimes it's not always clear-cut and easy to tell with our patients, especially if the patient tends to be apathetic. And so depression, the typical symptoms that we may see, sadness, being pessimistic, isolating themselves from their loved ones. But I think I wanted to highlight that one of the biggest symptoms of depression is actually irritability. And so you might hear from family members that the patient is short-tempered. So make sure that if the family is reporting irritability, that you should be ruling out depression as one of the causes. Also, it's important to note that dementia and depression kind of go hand in hand. And if you're not treating the patient's depression, you're going to see a faster decline cognitively as well. And so make sure that you're treating both. Next slide, please. Okay, anxiety. So anxiety, we do see this quite often with our patients. And sometimes, it could be something that's pretty obvious, where the patient is sundowning. It could be that they're wandering. It could be that they're pacing back and forth in their house for no apparent reason. Some of our patients will tell us in the office, and that they'll tell us, Michelle, I don't feel good. I feel nervous first thing in the morning, and I don't know why. And so your patient might be reporting those things to you. So make sure that you're also ruling out anxiety. Also, a key component of anxiety, usually the cause is because the patient does not have enough stimulation during their day. And so they're either not doing any physical activities, or they are doing more non-active activities like reading, or they're watching TV, but it's usually not enough stimulation. And so this is one, I know that when we have patients who are anxious, we usually will recommend things like adult daycare just to make sure that they are active. Next slide, please. Okay. Apathy. So apathy is the lack of interest in usual activities or even in their previous interests. Apathy, again, is very common for our patients, and it can be very distressing to the families. So here are some examples of what your caregivers and the patient's families might say to you when they are reporting symptoms of apathy. So it could be that my mom, she just wants to stay in bed all day. She just wants to stay in her pajamas and just eat snacks all day in her bed. That's a sign of apathy. It could be that the patient no longer is able to empathize to caregivers or their family members. And so the patients are less able to verbalize things like, thank you so much, I appreciate what you're doing for me, and if the patient is apathetic, usually they're not able to verbalize these emotions. It's very bothersome to families, particularly if the patient was somebody who was previously very active, had a lot of interest, maybe had high profile jobs, and then now all of a sudden they're not wanting to do any of those things or interests that they previously had before. So very bothersome. Next slide, please. Okay. Elation, I wish, I kind of wish that we saw this more in our program with our patients, but we don't actually see it quite often. Elation is when your patients seem like they're feeling too good or excessively happy, and it's for no apparent reason. Families might report that, she seems like she's high on something, and that's usually a sign of elation. Other examples that we tend to see in the office are, singing, dancing. I've had patients start dancing with me when I'm doing their physical exam, and usually it's not bothersome to me. It generally is not bothersome to families, unless it's something that is very, very excessive and bothersome socially. Sometimes you can see laughing, where the patient will laugh for no apparent reason, day, night, it doesn't matter, even if the family reports that they have bad news. So again, it's very distressing it can be very distressing to the family. Next slide, please. Okay, disinhibited behaviors. So disinhibited behaviors, I think probably one of my, not favorite is a strong word, it's not a favorite behavior, but I find it very interesting. Disinhibited behaviors, if you're going to think about this, just think about this picture that I have on the slide, because these are behaviors that are just simply inappropriate to society in general. It could be hurtful comments towards, clinicians, towards their family members. Sometimes it is overtly friendly behavior. I once had a family member report that her dad would go to the park on walks, and he would be so excited to see kids, kids who are strangers, and he would start hugging them. And although the patient's intention was not to hurt the child, from the parent's perspective, they were very bothered by this behavior. But again, disinhibited behaviors are behaviors that are socially inappropriate. And the reason that they're not having these behaviors is that they no longer have a filter on what is appropriate and what is not. Sometimes it can be very problematic in public, in that the patient will get in trouble with others, or sometimes with the law. So for example, if a patient is running out without clothing, or they're urinating in public. So that's a disinhibited behavior. And then sexual disinhibition, again, this is for our patients, very, very common. Next slide, please. So I just wanted to speak briefly on sexually disinhibited behaviors. So this can present in, again, several different variations of severity. So it could just be disrobing. It could be that the patient is exposing themselves to families or the public. Sometimes it could also be that they're delusional and they are accusing their spouse of having an affair. Sometimes, again, when it becomes very problematic is when they are doing it in public. So like public masturbation, that's very common. Or sometimes they can become physically intimidating as far as their sexual aggression. Very common for our patients to all of a sudden want to pursue, pornographic material, whereas they previously were not interested. So I think, when you are speaking to families about this, one thing that you do need to address is how the caregiver is coping with this behavior. Because more commonly, we do see our patients exhibiting this kind of behavior towards their paid caregivers, which is, it's certainly bothersome enough. However, we also have patients who are exhibiting this behavior towards their own family members, especially if they're no longer able to recognize their family member. So we've had patients who are disinhibited towards their children, towards other family members, and certainly can be very bothersome. I think, you know, for us who are taking care of our patients, please note that if it's a spouse, certainly family members, but specifically a spouse who is reporting these events, keep in mind that the event has been happening for a lot longer than they're actually reporting, and it's probably a lot worse as far as the severity. So typically when our family members are reporting, you know, sexually disinhibited behaviors, this is something that we track over time because we don't want it to get worse. Next slide, please. Okay, presentation. Oh, other presentation. So it could also be excessive flirting. It could be storytelling that you might hear. And you might hear this from patients who are in the very early stages of dementia. And again, it might also be the type of dementia really does play a part into your assessment, because I know that patients who are in the younger stages of dementia, as well as who are in the early stages of mild, or if they're younger, they tend to have a lot of these disinhibited behaviors. Next slide, please. Okay, irritability. So I think certainly, you know, we've probably noticed our patients having irritability in one way, short form or other. And it could be, you know, that they're cranky, or they are short-tempered, or they're very impatient with delays from their family, but also from medical appointments. Next slide, please. Motor disturbances. So motor disturbances are behaviors that tend to plague our patients over time. And I listed, you know, falls, having an unstable gait on there, because they're just no longer able to control their motor skills. I forgot to add aspiration on the slide, because again, this is, you know, aspiration is one of the motor disturbances that we tend to see with our patients, particularly as they are getting older and the disease is progressing. So also dysphagia. I put the slide on here because this is an example of neurotic excoriations, and I'm sure some of the clinicians have on this call have seen patients coming into their office with this type of, you know, of a skin issue. And so what I will typically see in the Alzheimer's Dementia Care program at UCLA is that, you know, there's a certain process our patients typically have to go through. So usually they'll show up at their PCP's office or their geriatrician, and they'll say, hey, you know what, my mom has been having a rash, and I don't know if it's itchy, but can you prescribe something for it? And then typically what we'll see is that the patient will get, you know, triamcinolone or some kind of other over-the-counter cream. They go home, it doesn't work, and then they go back to the PCP, who then may refer them over to dermatology, and it still doesn't work. And so, but these are neurotic excoriations, and kind of a little bit of a background on that is it's actually a combination of a couple of behavioral problems that are causing this. So it could be that they are depressed, it could be that they are very anxious, but also socially they probably don't have enough to do, so that they're kind of picking at their skin. Next slide, please. Okay, sleep disturbances. So sleep disturbances, unfortunately, it does affect about 25 to 50% of all of our patients. And, you know, certainly it gets worse as the disease progresses. And also when there is some kind of a hospitalization or some change in the patient's environment that causes them their sleep to be impacted. So what is insomnia? Insomnia could be difficulty falling asleep. It could be difficulty going back to sleep after they've woken up to use the restroom. For our patients who have delirium, certainly it wouldn't be uncommon for us to see that they have the daytime and nighttime reversal. And that's when, after the hospitalization, they go home and then they are asleep during the daytime, and then they're wide awake during the nighttime. That is a daytime, nighttime reversal. Also, I just want to note that donepezil, which a lot of our patients are taking, one of the side effects of donepezil is that it'll give the patient nightmares or vivid dreams where the patient feels like they are, I've been told, Michelle, I feel like I'm watching TV when I'm sleeping. So they're not sleeping well. Next slide, please. So causes of sleep disturbances that are not related to dementia. And so again, we'll talk more about this in the part 2 of behavioral modifications is, why is the patient not sleeping well? And it could be all of these things, alcohol intake, caffeine, a lot of daytime napping, and our patients tend to do that if they are bored or if they don't have enough stimulation at home. Next slide, please. Okay, appetite changes. So appetite changes, it could be weight loss or weight gain. Weight loss, we typically see that in our patients if they're in the beginning stages. If they are not having enough caloric intake in their daytime. And this is what we see with our patients who are living alone and family is not able to figure out, like, why is my mom or dad losing weight? So typically when a patient comes in for weight loss and we've evaluated, we've ruled out everything else that's causing weight loss, I'll ask the family, what does mom or dad's appetite look like when you guys are eating together? So if they tell me that, oh yeah, we just went to dinner and she had a whole plate full of food and her appetite was really good, then it's usually pretty telling. And it tells me that the patient's appetite is actually pretty fair or normal. It's just that they're not getting enough calories because they probably live alone and they don't have anybody who's helping them. Weight gain tends to not happen as often, but weight gain is usually when patients are not getting the supervision that they need, and they're just kind of like eating, whatever they want during the day. Next slide, please. Okay, so the initial care plan, so what do you do when your patients are showing up with these behavioral problems? First things first, safety, always assess for the patient's safety. And again, as I had mentioned earlier, assess the patient's ability to inflict harm on themselves as well as the caregiver. When we are drafting the initial care plan, you really have to provide support to the caregiver, and that could mean actually a lot of different things. But when you are talking about safety with a patient's caregiver, it's important for you to have this conversation because some of the behaviors are certainly more bothersome than others. So, for example, if I have a caregiver who's reporting that, my loved one is hurting me and I have bruises, or my loved one is sexually assaulting my mother, and this is a problem that is, really taking over our lives. And these problems do actually happen. And so it's important for everybody on this call to, again, talk to the caregiver and say, what is actually happening at home? And tell me what's going on. How often is it happening? And as a clinician, if you are seeing your patients and they are obviously very distressed, it's important to give them options, like discuss options. The words that I typically will use in the office is, especially if there's some kind of physical trauma, I will say, I'm really so sorry that this is happening to you and your family. This behavior is not okay. And then usually that's when they kind of have like a breakdown, emotional breakdown on what's been going on at home. A lot of families do worry about the ramifications of them, of what's going to happen if they call for help or if they report it. If there's actual physical damage or even the threat of it, I usually will verbalize, again, this is not okay. I want to work with you to try to take care of your mom and your dad. And if your goal is to keep them at home, I really want to make sure that things are safe for the both of you at home. However, the situations that you have brought up to me today during today's visit, they really are an emergency. And so during this time, I will reinforce, 911, and I will talk to them about a 5150. There's also certain cultural considerations with supporting the caregivers, because a lot of cultures will not encourage caregivers to bring up these situations to their provider. And so kind of keep in mind that if the family is reporting it to you, it's usually a lot more severe than what they're actually reporting. Next slide, please. Okay, the initial care plan. Next slide, please. Okay, caregiver assessment. So again, part of your evaluations when you're seeing your patients is that you are looking at the caregivers, you're interviewing them, you're trying to see where they're coming from. Because again, this is going to help you determine your recommendations. So caregiver assessment, part of it is their level of education. What is their preferred way of learning? What is appropriate? Are they more willing to learn if you give them, a link? Or is it something, if they're older, maybe perhaps consider something that is written, or even like a hard copy of a book. If you are encouraging for them to pursue, online resources, you have to look at their health literacy, but also the social drivers of health. And you need to look at simple things like, do they have Wi-Fi? Do they know how to use Zoom? Do they have a laptop to access this information? And so that's a part of your care plan. So when you are recommending, whether it's support groups from the Alzheimer's Association, or maybe a counselor, or even one of the family educational sessions at the community-based organizations, then all of those assessments, all those recommendations, you need to assess the caregiver. Next slide, please. Caregiver education, I think I spoke about that already. Next slide, please. Okay, also identifying triggers are important, because they're actually, the caregivers are the best resource for getting a good interval history and report on your patients. So teach the families how to identify these triggers so that they're able to hopefully prevent some of these behaviors from happening. And again, identifying the appropriate social activities and adequate physical activity. Next slide, please. Okay, and again, just a quick reminder that part 2 of this presentation is going to be coming on October 24th. Next slide, please. Oh, I just wanted to, I know I'm kind of short on time, but I just wanted to share this resource with everybody on this call. So if you go into our website, as well as look into these QR codes, then you can see videos from the UCLA ADC program that we developed. And it's great because they are snippets. It's about a 3 to 4 minute video on each particular behavior. We have them in English, Spanish, and also some other, I believe there's also 8 other languages that it's available in. Next slide, please. Okay, very briefly, I just wanted to talk about the other key offerings that is available, through UCLA and through the Dementia Care Aware grant. So the education and the support that we provide clinicians is very different. And we designed it so that it's driven by the learner's needs and objectives. So each offering has different intensities and levels of commitment. Next slide, please. Okay, so the first one that we have to offer is the Dementia mini course, and it is an online mini course that is available through the Dementia Care Aware website. And it's useful for, as you can see on the target audience, it's a great way, and it's actually appropriate for teams to participate in. These are videos that you can take at your own time, and I think for me, a great way to get free CMEs during your lunch hour. It's free of charge. Again, compliments of Dementia Care Aware. Next slide, please. The National Dementia Care Collaborative, that's the NDCC. So it's a community, and it's a great community that there's a lot of people who are participating on it, such as developers, policymakers. So we have some government staff on there, and also, other developers of complementary dementia care models that we have been collaborating with in the past few years. So it's a great way to increase your knowledge, but also your support and participation in dementia care. That's also the NDCC is also something that we offer. Next slide, please. The ADC Echo series, and again, thank you to UCSF and also the Dementia Care Aware grant. We are able to we offer the ADC Echo series, which is a 6-month session, and it's usually 1 hour every 2 weeks. It's a great way for, if you're a clinician and if you're wanting to participate, it's great, but it's also a terrific way for your whole team to participate in. You get free CMEs, it's free of charge, and the first, it's about an hour long. So the first half hour typically is spent on some kind of a didactic, like a lecture. And then the other half of those, the hour is spent on clinicians who are wanting help and support on challenging situations. Next slide, please. Okay, the ADC dissemination program. So, that's what I do. And that's actually the highest level of support and commitment that we're able to provide through Dementia Care Aware. So as part of the dissemination, we actually provide training for clinicians, APPs, MDs, as well as their interdisciplinary team on how to start and implement their whole dementia care program. And our program, it's an outpatient model. Typically, we have, let's see, I believe up to date as of this morning, UCLA is the first site. We have been able to successfully implement the ADC program to 18 organizations nationwide, and we do charge a fee of $50,000. I just wanted to mention that, again, through Dementia Care Aware, if you're coming in, if you're a provider who's working in California and you provide care for patients who have Medi-Cal, we are able to waive that fee of $50,000. Next slide, please. And then guide, I know that many of you are very familiar with the guide model, which just came out last month. And again, the purpose of guide, the objective of guide, is to improve the quality of life for patients who are living with dementia, but also to now provide support and resources for caregivers, unpaid caregivers of our patients. We added the link on there so that if you're interested in finding more about the model, you can go on this website. Next slide, please. Also, another service that we offer are referrals to other dementia care models. So while the UCLA Alzheimer's Dementia Care Program is a great program, and where we come from, it's not always appropriate for all organizations, depending on the resources and the amount of staff they have. And so again, we are working with the developers of these other models. So if we think that you're more appropriate for these other models, then we will certainly refer you to the appropriate person. Next slide, please. Thank you so much, everybody. Sorry, Dr. Chodas, I know I ran out.
No, that's okay. And I appreciate there's so many resources, and obviously we get super excited to tell everyone about them. But it's also an important time for some of these opportunities like Guide, which is why I really appreciate that you brought that up. And just to put it out there, Michelle very kindly, I believe, we can share your contact information. I think if anything comes up, dca@ucsf.edu is another good resource for questions about like more in-depth training, education. And
absolutely. So I think we have my project manager, Jagrup Kaur, should be on this call. And so if she hasn't already, her email should be on the chat somewhere.
Okay. That's great. I want to take a few minutes because we have about 8 minutes, which is a decent amount of time to address some of the questions because there were some really, really good ones. I think one thing to note is you came out of the gate, I think, reviewing some of the more serious, or I would say severe, perhaps more noticeable behavioral symptoms. And so there was a question, which I think was a good one, about how do we think about some of the symptoms that we consider behavioral symptoms of dementia and stage or like severity of illness? Do they, all these symptoms come up all the time, or how should we think about that? So if you have a brief rule of thumb for that, or how to think about that, that might be really helpful for everyone.
Yeah, and I'm not sure if I can answer it, and I think would satisfy the question, because all of our patients are so different. And so patients who are coming in, let's say who has, a MoCA of 10 or 12, and they're in the fast 6 or fast 7 stages of a disease, not all of these patients they might not have any behavioral problems. And so typically, when we're looking at the severity of like their clinical presentation as well as the actual behaviors, sometimes, we do consider it, but yeah, it's challenging. Typically, when we see these behaviors, we do talk to the families, and depending on the severity and the type of the behavior, we will continuously talk to the caregivers and say, okay, I know that you had mentioned that she seemed a little bit down our last visit. How has her mood been? Is it more developing into depression, or is it no longer bothersome? And so these symptoms, even if we're not medicating the patient for it, we're constantly evaluating if they are progressing or getting worse. I don't know if that helps.
Yeah, I mean, I think I often find or sort of talk about the fact that certainly with typical, for example, Alzheimer's disease, maybe we're more likely to see hallucinations in more moderate or severe stages and not quite as early on, where it might be more delusions and, sleep disturbance or something like that. And everybody's different. Everybody can sort of have these symptoms come up and then abate. And then it might really also be dependent on what's going on. So people with Lewy body dementia, for example, are just often report a lot of sleep trouble and psychiatric or more typical psychiatric symptoms like hallucinations earlier on. So I think, to me, stage doesn't mean that certain symptoms can't happen, but certainly they get either more severe or more typical depending on like kind of what disease process is going on.
Yeah, and I think
it was a really good question. It can be hard. It doesn't necessarily map out exactly is the way I think about it. And sorry, Michelle, please continue.
No, I was just going to add that I think that's a really good point. So like, for example, our patients who have FTD or Lewy body, typically their MoCAs stay intact for quite a while, and can stay that way for a few years. And that's not so bothersome. What is bothersome is some of the behavioral problems that they're having, like the disinhibited behaviors, the depression, the anxiety. That tends to be more bothersome than the actual stage of the disease, if that makes any sense.
Yes, it does. And I just want to point out that folks are asking for the CME, so I'll ask my team to put any links they have for that. Thank you. The link is now in the chat, so please claim your CME if that's useful to you. Sorry, I'll keep that up as well. That's super helpful. I think the other comment that somebody made that I wanted to bring up, just so everybody heard it, is, some people may seem irritable, or we're labeling them as irritable, but they're actually, and maybe I think it was the example you gave, they're responding to a reasonable thing, which would be, they want to do something for themselves and other people think they can't. And so how do we distinguish between irritability or something that maybe is more abnormal, or we're looking to treat, which I'll plug, will be discussed in the second part of this series, or versus like, hey, that was pretty reasonable. They're an adult who's used to being independent, and now people are removing that agency, and it may be inappropriate. It may be more of an ageist or ableist kind of, thing that's happening instead of a reasonable offer of help. So I don't know if you have any thoughts about that, how you would distinguish when it's really irritability versus, that person's responding to lack of autonomy.
That's a really good question, because if it's irritability, I tend to, I look at the triggers. So sometimes irritability, is the irritability all the time? Is it every day? Or sometimes you'll hear from family members like, oh no, she only gets really irritable and agitated towards one caregiver. The rest of the time, she's okay. If I get the sense that the irritability is impacting that patient's quality of life and able to have meaningful relationships with their families. Also, if this is a big change for them, maybe they used to be very friendly and loving, and now they're just hyper irritable, then I think that's a worthy reason of exploring possibly treating that patient with an antidepressant, because it is having a significant impact on the patient's quality of life.
Great. I think there were other questions. There's so many good comments in the Q&A, so I'll recommend that people read through those. I think there was a lot of questions about like when things are sort of more in line with depression constellation of symptoms versus dementia behavioral symptoms, and how we would parse that. It's like pretty much, I think apathy was there was a good question about apathy specifically. And I think you were sort of starting to get to some of that as well. Like, how is it affecting their life? Maybe it's worth treating empirically anyway. And then I was just commenting, I often look at past history, like have they had a history of depression? Is this a pattern for them versus is this totally new and consistent with the development of other symptoms that seem to suggest more dementia? I don't know if you have any other thoughts on that. We have about one more minute.
I think, and not just necessarily depression, but all of these other behaviors. If it's not bothersome to the patient and certainly not bothersome to the family, I'll leave it alone. I won't treat it. But again, if it's having an impact on the patient's quality of life or the caregivers, then I'm more likely to think about treating it. And by treating it, I'm talking about with pharmaceutical agents. Obviously, you always want to, which we'll talk about in part 2, you always want to exhaust behavioral modifications that the family can do before you go to pharmaceutical recommendations.
Thank you. What a good plug for the second part of this, because we're going to talk about more care plan treatments. And I'll just say that some questions I thought were really good also came up about, when there's risk of harm, imminent harm to people or around the person living with dementia, or self-harm, and how we think about holds or, more escalated concerns around like 5150s and when do we see those applied. So a plug to all the wonderful folks who tuned in today. We'll try to address that impart at the next session. And I'm just so grateful. This was an incredible session, really great turnout, and we welcome your ongoing questions and comments. And feel free to email us at dca@ucsf.edu to get more comments to prepare for the next session, so we can really serve what you guys were hoping to hear and what you're seeing in your clinical practice. Thank you, everybody, for your participation. Thank you, Michelle. This was terrific, and we'll see you soon.
Thank you, everyone.
Have a
Have a
good
great
afternoon.
Bye.